I would like to start this discussion with a number, which rather want to start this discussion by reinforcing one number, which says that around 80% of population of this country is not having any health insurance. This in itself suggests the kind of health insurance coverage we are having in this country. There are many reasons for this. Lack of awareness, affordability, we don't have hospitals, doctors that cater to the demand, and which has led to rise in medical inflation. If we ask experts, medical inflation is as high as 20 to 25% in this country. In this background, I will pose questions to all the eminent speakers over here and will ask intrinsic issues relating to health insurance, be it product design, distribution or technology. Having said that, the focus of this panel discussion will be on how to make health insurance coverage affordable to all. I would like to introduce all my panelists over here. Sanat Kumar, he is CEO and MD of National Insurance Company. Varinder Singh, he is MD and CEO of IFCO Tokyo. Nandan Ali, she is Chief Marketing Officer of Apollo Munich Health Insurance. Pankaj Tomar, he is Chief Underwriting Officer for the India Reinsurance branch of EXA. We also have with us Dhruv Sarin, he is Head of Health Insurance at Policy Bazaar, and Mr. Patnaik, who is representing IRDA. Let me break this up and start with a common question. And after this, it will be open for Q&A round. Mr. Sanat Kumar, I would like to start with you. How do you look at the health insurance status in the country? Do you think health insurance is really affordable for poor and middle class section of the society?
Thank you, Tina. See, you mentioned in your introductory remarks that is it an issue of product development or distribution issue? I would like to slightly deviate from those elements. The products are there, the distribution channels are there. What we are really facing is a trust deficit. The younger group, the healthier group of the population are not coming forward to buy this insurance, thinking that this policy is a very complicated document, and when I'm hospitalized, insurance companies may not come out with the amount and I will be left rich. This is one thing which we have been really struggling with. See, because one case here and one case there gets flared up in the media, and it gets the thing is that one district consumer forum has awarded that, one district consumer. We settle 90-95% of the thing in time and to the satisfaction of the customers. It's only the 5% that creates all this kind of distrust, and that gets reported in the media, that gets reported in social media, and that gets widely discussed as well. So, I would tell any insurer who goes to the market, our agents go in the market, would you settle a claim at the point of time? And we have another issue is that most of our claims are handled by third-party administrators. Many of the companies have different model, but the public sector insurance companies, we go for cashless facility. Our identity is subsumed in a third-party administrator's identity. So this is one issue, because many of the insured customers, the patients feel third-party administrators are the insurers. So they're not. They are only the interface between the patients, the hospital, and us. So any mistakes done by them or some kind of thing get thrown into us, and then we also have to. So you has a ring of distrust among the public about the complex modalities about taking a policy and claiming the policy when the time comes. I think this is an issue where we need to work on through substantial awareness. The regulator is also aware of this. They're also putting in a lot of might to see to that. There's a lot of awareness. It's simple. They come out to see that there is a protection to the policy holders. If there's no claim, you please come to us. Go to the office, and they keep on telling everyone. But still, we find why the young are not coming voluntarily to take insurance. This is their question. Though products are available, companies are there, channels are there.
Your opening thoughts, sir?
I would actually like to carry on with where Mr. Sanat Kumar left. And again, a personal opinion. As insurers, we are a very maligned lot. The deficit, the trust deficit is very much there, as he said. The general impression is that we do not pay claims, despite the fact that, as Mr. Kumar mentioned, that more than 90% of the times we pay the claims. When we go to pick up the premium, it seems like such a thankless job. From my personal experience, I could tell you, for 30 years I was in the general insurance business. I still am in the government sector. And then for 4 years, I went to housing finance, and I felt so good because for a change, people were coming to me asking for money. That is, for 30 years, I had gone all across, and to put it very crudely, it's like you're going with a begging bowl, and you still put on the last priority. People don't even want to, meet you because they're into this. The general feeling is, "Phir aa gaya hai." With a life company, they still feel that the end of the day, when the policy matures, if something untoward has happened, obviously you get compensated. But if that were not to happen, you would get something, when the policy matures. Here they have a feeling that you get nothing out of it. Now, when you look at the data of this country, 70% of this country's population is below the age of 35 today. When you're young, you think, the world in your pocket. Why do you need insurance? Why do you need health insurance? After fit and fine. Now, which is where, for people in the young age bracket, if the company that they're working for, if it provides for insurance, wonderful. Or when it's time to get married, when it's time to start a family, then one does think in terms of the little maternity that also accrues out of that. But otherwise, nobody thinks of insurance. Whoever, even if he or she has the capacity, but they would rather look at something else. For them, a vehicle insurance makes sense because you travel, it could get stolen, it could get damaged. But as far as your health is concerned, you never think that anything could happen to you. We hope that gradually this feeling creeps in. Now, in fact, I was not aware of this, but genetic engineering, it's something a couple of companies have come into this country following the model that the American and the developed countries have done. So it's a once in a lifetime diagnostic test that you undertake. And it could suggest and reveal the illnesses or the maladies that you could be vulnerable and susceptible to based on your genetic background. And I would subscribe to this and suggest to as many people possible, because probably, once you get to know that at a later stage you could be in line for it, you may think in terms of insurance. When I look around these days, when I look at the number of people, all of a sudden you realize cancer developed or detected in the 4th stage. Young people getting, cardiac infections. All of a sudden, life crumbles. Then people run from pillar to post. That is the time when we insurers become like the most favored nation. And obviously, when you've been a part of an insurance company, you've been taught to do prudent underwriting, you definitely don't want to come into the picture then. So probably that awareness has to be brought in. The media has to play a major role. As Mr. Sanat Kumar said, we get the flak at any given opportunity. Nobody ever talks in terms of 95% of claims have been settled. We're actually bleeding. In my speech I did mention in terms of numbers. The loss ratio in itself on an average is 112%. Which means for the 100 rupees premium that I get, 112 I'm paying just in claims. Let's not add my management expense, my commission, and my operating cost comes into a region of 130, 135 against the 100 that I earn. Does it make any kind of business sense? And yet, do we deserve all these brickbats? So probably forums like this, or as I said right at the beginning, I think the media needs to play a very major role. And what the Secretary Health talked about, probably wellness. I do agree with him. In fact, I had that in my little talk that I was wanting to give, but I had to hurry it up. Because to my mind, I agree with him totally. If we were to put a lot of thrust on wellness, it could be like prevention. Prevention is better than cure. So that is it. It's not that people cannot afford to pay the premiums, but that thought doesn't cross. And as Mr. Sanat Kumar said, probably after 5 years, 5 to 10 years, when the older population, eases out. Sorry to use terminology or to even think like that. Then it would be the young Turks coming to the party. So let's hope it opens a level field for us people also to partake in a healthy and a kind of a little win-win. In fact, as insurers, we're not even greedy. I tell my customers and everybody, allow me just to earn a rupee. Just allow me to stay afloat.
Senior citizens, and their health insurance premium has been jumped by 50%, which is a huge amount. And they are not the ones who have just bought it. They have been paying premium for last 15, 16 years, and their premium, when their need has come, it has been shot up by as high as 50%. So how do you justify that? You say you buy early. These guys have bought early in their life, but still they have to bear the pain, especially in their old age.
I would disagree with you at a level that a lot of these people whose premium rates are hiked up are not people who've been there right from the beginning. These are people who've joined a few years ago and who
10-15 years, I'm saying.
And who already got into distress, who already had enough claims settled. So when the claim ratio is very, very unfavorable, insurance teaches you that you need to hike up the premiums. Also what happens is a lot of times people go in for wellness rather than the cure itself. That adds to it. And it could be made up by the young people paying the premiums. To give you numbers, I would think 5 lakhs sum insured for a floater covering a family of 4 up to age 35 should be got at about 8,000 premium per annum. Please correct me. I think that is possible, which is no great number. Look at the young people, they go for an evening out to dinner and would spend much more than that. So it's just a concept, it's a way how you think about it. Now, if these people from this age itself start adding to this kitty, they would realize that this is like a voyage, So for the rest of the people, the burden would get reduced.
Mr. Patnaik, if you could share your view when companies raise their premium rates, and even most of the time intimation letter doesn't state the reason for rising in premium rates. So as a regulator, what is your take on it? Because I'm sure approval goes through you.
Yeah, as you told, the premium has been increasing, and at the authority we are receiving a lot of complaints, especially from the senior citizens. I think hardly a week goes when we are not dealing with such complaints. But as already told by Mr. Sanat Kumar and Mr. Rohit Sinha, this is a thing which cannot be helped. This kind of rise in the premium. But of course, what the authority has done, we have notched the insurers to keep a cap. It cannot be, recently there was one instance where it was increased more than 300% after 1 year. So which is unthinkable. Especially senior citizens, they deserve and they demand also better treatment. But as you know, health insurance is one such thing. As age increases, the cost also keep on rising. So what I feel, because see, it is a group. Within the group, if the cost is high, it has to be borne by that group. And as already told my preceding panelists, there are not enough young people to support. So probably, it is not the question of affordability, as he has already given the example. It is more to do with the awareness. And more young people should come on board. So maybe when people, there could be multifocal things to be done to see that more and more people come on board. Because as you know, in insurance, more the numbers, less will be the burden. Because it is shared by the entire that particular cohort, that particular group. So what should be done is, I think at the authority level also we have also requested various governments. I think 2-3 state governments they have done. they have included certain chapters in the school syllabus also as to what is the importance of insurance and within that what is health insurance. So maybe if the children are sensitized from their school days to curriculum, or as told you in the media also, it is important. And when senior citizens come for insurance, if there could be a mechanism, they could be prevailed that why you alone, try to prevail entire family. We should consider even children also. There could be a mechanism that they can be persuaded that if you come, your insurance, your premium will come down per capita. Maybe the entire family will stay. And maybe it will give rise to more and more family coming together and floater scheme, group schemes. They cost less compared to if an individual goes for the insurance. Probably there is a need that we should move in that direction.
Nandini, what is your view on affordability of health insurance in India?
So, taking it forward from what the other speakers have already spoken about. So, in a country where we have 1.3 billion population, perhaps we have over just close to a 1 billion mobile handset users. Some statistics that we went through said that 40% of these mobile handset users are smartphone users. What must be the average cost of a smartphone? Plus 10,000. And as Mr. Wagner said, an average cost for getting a family floater for a 5 lakh rupees coverage would hover around 6,000 to 8,000. It is not the question of affordability. I think we're addressing a wrong question here. The question that needs to be addressed is how do you actually get the attention of this addressable population and move their mindset from choices that are more desire driven to the choices which are more basic in need. So that I think is very important, and as Mr. Patnaik also said, there is a lot of effort that the regulator is taking in order to create that awareness. But I personally have a very radical thinking. In India, we find motor insurance being mandated, right? India is a human capital asset country. Isn't it a very paradoxical that we don't make health insurance mandatory? Now, if for a minute, if you keep the entire BPL population, which has become the subject of the government, and the government is trying to do a lot many things under the national health policies and so on and so forth to take care of the requirements. The APL population which is there, why don't you mandate health insurance for the APL population? There are very many ways that you can actually bring this about. A couple of years back, if I'm not mistaken, the CMD of New India were also talking to the ministry about why don't we introduce a birth insurance, right? Start to practice early in life, right? Any practice which you practice for an onset is on an early side, it actually becomes a habit. So all that we need to also do is to look at how do we actually change the health-seeking behavior, how do we change the seeking behavior of dispensable income that we have in hand. So I think that is a bigger problem than talking about affordability. There is money, people can afford healthcare of 5,000 rupees for the family.
Pankaj, you represent the reinsurance business over here, and the company has vast experience in foreign market also. So what is your view on this whole affordability thing? Is it really that not much advertisement has been done, not much awareness has been created, or some problem with the product design? What do you think? What is your view on this?
Well, I would like to share some of the constraints or challenges which the reinsurers have been struggling with, and those constraints will not be very different than that of a direct insurer. And before that, I would like to draw some parallels between the retail health insurance and there is something called aggregated retail, which is like a state government, basically deciding to take insurance for a certain set of people, say BPL population. One name is probably RSBY, and so on and so forth. If you see how aggregated retail has evolved in last 1 decade, so I'll take you to very basic fundamentals of insurance. So when we design a product or price a product, there are two very basic things. One, we take into account the number of lives we expect to be insured, and For a aggregated retail kind of a situation, there is a state government which is in a way committing that okay, there are going to be 50 lakh people for which we are going to take insurance. So that basic fundamental, first fundamental, that we are meeting that law of large number as far as insurance is concerned is going to be meeting there for the aggregated retail thing. Another fundamental thing is that there should not be any adverse selection. So when we sort of mandate some insurance for a certain set of population, then it is mandated for everyone. It's not that somebody who really wants it will go and take the insurance. So these are two basic, fundamental, things which we in insurance or reinsurance industry look for when we price a product, and that is what is missing when we come to retail health insurance. So previously everybody has talked about that there is adverse selection. At the same time, if I talk about say distribution, so taking say e-commerce into consideration, and there is a lot of talk, and my fellow panelist is also there. So and looking at how the market is converting into digitally changing. Why not use e-commerce and reach out to as many people as we want to meet that law of large numbers? But fundamentally, what we have seen is that either we have not been very successful in meeting that law of large number, even using those digital channels. One cause could be that when I go and introduce a new channel, they start conflicting with my existing set of channels which are already there, and that is why we are not really meeting the kind of numbers we expect to meet with. That is number one. Number two, what we have seen that although there are channels which meet that magical law of large numbers, but then do not really qualify the adverse selection criteria, which is very, very important for us. So these are two fundamental differences when I say between retail and aggregated retail, and that is why if you say aggregated retail over a period of time in the last 10 years has become really affordable. I would say that even for retail health it is very much affordable, but yes, the penetration is missing, and the penetration is missing only because we are not meeting these two basic criteria. I would also like to take up one question which is there in the previous session. Somebody, I think Sethi posed that question that why not state governments, they should come up and have their own insurance companies. Now, the way I look at it, state government coming up with a monoline insurance company, be it crop or be it health insurance company, don't you think that company will be a lot more under pressure to correct the price? Because either that company should not be taking any reinsurance and create that insurance company as a pool. That is one option. If they decide to go for reinsurance like a normal traditional insurance company works, then it will be very difficult for a reinsurer to provide protection knowing that they are going to be a mono line and mono state company. So getting reinsurance for that company will be extremely difficult, and they will be a lot more under pressure to correct the price than how currently all of us, including facing that problem. So though it was related to crop, but I think it is relevant to health insurance as well. So now coming back to that question of yours in terms of affordability, distribution channels, and the pricing, I will put it this way that in last few years there have been a lot of innovations on the retail health side also, but there has been a problem of scaling up, and we have to have either we should have some kind of public-private partnership, or we have to have insurer-insured partnership, wherein the concept of co-payment comes up. So this, emerging middle class or lower middle class or middle class can really come up and take the health insurance, which currently they are not taking. So I think, according to me, these are a few, factors which will drive this insurance in the times to come.
Dhruv, you represent the technology aspect of it. You are into distribution of health insurance policies. So, how do you look at the whole space? Is affordability the issue, and you are into technology? So, do you get the advantage in terms of pricing over there? So, what is your view on the whole space?
See, we've addressed that whether it is affordable or not affordable. I think there are two sections out there. One who can afford and are not buying, and the other who want but cannot afford. Right. So primarily, if I look at, as in the previous session was mentioned, that people, the labor class in metros, right, who are more susceptible to the typhoids and the dengues of the world, they want insurance, but somehow it's not affordable to them. And then there is this below 35 segment who can buy a smartphone in once in 6 months, but does not think health insurance is cool to buy, right? So I think both segments, I think the challenges are different. If I talk about the affluent class or somebody who can afford to buy and is not buying, I think fundamentally, as sir mentioned, that they think they are fit and fine. They don't need health insurance right now. Post 40 is when they should start considering about health insurance. I think there we get such customers on our platform, and then we get such customers in boards. So today, if I talk about the kind of traffic, I think we've got more health insurance searches on Policybazaar as even more than Google, right? So today, as Policybazaar, we can kind of say that we are the default destination for health insurance as far as online is concerned. But still, only about 10% of the customers end up buying. The 90% don't end up buying. They have questions. They talk for about 45 minutes to an hour. They ask about various things. What is covered, what is not covered, but they still don't buy because somewhere they are not seeing the value of that 8,000, 10,000 rupees. And we've done enough FGDs, enough surveys, spoken to enough customers ourselves. So I think fundamentally, from a product perspective, I think there is scope, as I would call it, so that the customer starts seeing its value. Now the value could be, if I'm paying 8,000, what is it that I'm getting back? The value could be, I'm paying 8,000. Is the insurance company working with me to improve my health? The value could be, why do I pay 8,000 and I hear that premiums are going up once every 3 years when I know I have to make a claim after 20 years, right? So I think for each value-driven feature, products are there. Somewhere consumer need to be more educated. For example, wellness. I think today, if you look at the new product launches that are happening, the whole concept of wellness is how do you make the consumer healthy, right? Basically, the 8,000, 10,000 rupees that the customer is paying, and the insurance companies are engaging with the consumer to ensure that they stay healthy, right? Now, this piece has to be educated enough. I think once that education comes in, value will be seen. The other is, as I said, why do I pay 8,000, 10,000 increasing for 20 years when I know I have to make a claim for 20 years, right? So in fact, we've been speaking to a few insurance companies, and they have approached the regulator also. Have discussed such products where we say that the customer pays a premium for only about, let's say, 3 years, 4 years, 5 years, and after that, till the time he does not make a claim, he does not pay anything. Now suddenly, that is when the customer may start to see value. This product will have its own set of challenges, right? And that's what we've been, kind of speaking to actuaries of insurance companies and the regulator also. Does this make sense? Will with this product where a 25-year-old says that I pay premium for 4 years, 5 years, and then I don't pay premium, or I pay a very minuscule premium till the time I make a claim. Then the consumer may start to see value, right? So the point I'm trying to make is they do understand the young class understand the value of health insurance. Somehow they do not. They think, not right now. Let me just postpone the decision. अभी क्यों खरीदूं मैं? I am fit and fine. I go to the gym. I don't see value, right? So I think that's one segment. Definitely, as sir mentioned, trust is a big deficit. I've spoken to umpteen people. In fact, I was at the immigration a few weeks back, and the guy said, "Where do you work?" I said, "I work in health insurance in Policybazaar." He says, "यार, मतलब insurance company तो चोर है." I said, "Why?" He says, "1 lakh का claim में 90,000 रुपए देंगे." Right? So that 10,000 is valid deduction. It's not invalid. It's like the consumables are not covered. And consumers know when they're buying, they know. But somewhere at the time when they need 1 lakh rupee, they only get 90,000 rupee. right? So that education and that trust building, which I think everybody from from the regulator who started radio ads to the insurance companies to us also are trying to educate consumers that one, know what you're buying, and second, if you do not get a claim, please be rest assured that one, insurance companies are not there in the business to deny claims; they are in the business to pay claims, right? And they are paying genuinely. It's just that these things are not covered. So I think trust building is important. I think the second piece which I touched upon was
we cannot afford anyway. So I don't think 15 to 18% that escalation has really been a dampener on the demand for health insurance. Well, that's my personal opinion.
But you are saying you have passed on the...
No, entire 18% we charge to the customer.
Okay.
Yeah.
But the government said that in the long run prices will come down. So will it going to happen?
Not really.
Not yet. Shanti, what is your view on it?
While yes, sir is very right that we have not seen a slowdown of the business despite the GST thing. But how we look at it is when you're talking about the entire healthcare, right, there is a provider, right, which is a hospital. The care from the provider has been exempted. Right? And what is health insurance? It's just creating an access into the provider. Right? So why not exempt health insurance from the GST or lower it down? Since we have been talking about handling the issue of penetration and affordability, these are the things in the long run we think will definitely have an adverse impact. So the submission that we would have in case there are any government representatives here is that please do consider exemption of health insurance in GST. Another thing, when you spoke about, on the digital, I think Dhruv is the best person to address that. What we have seen is that it's just not the distribution alone that actually counts in making the penetration happen. We heard the statistics in the first session, which spoke about despite all this digital air which is all over the place, the penetration of insurance online is only 1%. Now, one has to obviously look at when there is an access of information, because it's plethora of information which is available. You have aggregators like Policybazaar who actually serves you the entire thing in a silver plate to identify which is the best product for you. And despite that, there is a fallout of 90% is what he says. Then where is the problem? The problem could also be in the way that we are drafting the products. Right? Today, people don't have patience. And that's very evident from the fact that mushrooming of fast food joints and so on and so forth has become so much. Right? People need quick, easy solutions. So there is definitely a requirement of looking at products. For example, there are companies who have come up with an OTC kind of product, over-the-counter kind of product, which does not need any underwriting. So those kind of products can definitely sell very well through Policybazaar kind of aggregators. So we have to look at more products which can actually be green channel products, which do not need the entire plethora of battery of investigations under the garb of pre-policy checkup and so on and so forth. So easing out that framework is also equally important.
I agree, simpler products will surely solve the problem. Virendra Singh, I have a question to you. Since we were talking about coverage of health insurance policies, so why can't we include modern ailments more in our health insurance policy? I tell you where I am coming from. Like depression is a huge problem in the country, but health insurance policies do not cover depression. WHO study says that 5 crore people in India are currently suffering from depression. So when a person goes to the hospital and the hospital says no, depression is not covered, trust just zooms down. So why can't we have more and more ailments covered in our policy so that we don't have surprise at the last moment?
We will be depressed.
Health insurance is already a depressed topic.
A very tough one. And also supposing, one got into this line of business even after the actual study and come up with a premium rating. I think when it comes to the claim settlement, it would be extremely difficult to, document and figure out what is the claim payable, unless and until all that they're looking for is, a fees that they pay to their psychiatrist. Because if it is not that, and if they're not going to work, then we are probably looking at a loss of business, situation later on.
It's a serious issue in the country. Why can't bills be reimbursed?
I think in our country it is still not as serious as much as it is in the countries.
3 out of 10, 3 of my friends are depressed currently.
So basically, we're looking for solution for them.
Yeah, mental illness has been something that has been consciously kept outside the ambient of health insurance since time immemorial. One also have to look at what is the social environment around the mental health today. And it has been the same in the past as well. Today at least people are talking about, you talk about 3 friends, depression. There is a stigma when it comes to mental health. First, people do not discuss about it. And second, going to a psychiatrist is also a bigger stigma. So that actually has led to the fact that there is very, very limited data which is available for the actual scientists to craft a risk-based pricing for this particular disease. Second thing is, if you really look at the statistics around the availability of the supply, as in the specialist to actually take care of this requirement, 0.3 psychiatrists are available for 1 lakh population in India. Which is like unimaginably low, and this is available for an urban population. Absolutely nothing out there in the rural India. So that is another reason why the mental health has not been included in the policy. But I know that most of us do have this particular illness covered in the group policies. Right? In the retail we do not, but yes, in group policy we do cover.
My point was not only depression, even dental care is not covered. So larger coverage is the solution for building trust among policyholders.
So if you really look at it in the entire healthcare spectrum, right, you have the preventive, promotive, outpatient, and emergency, and then the hospitalization cover. So most of the solutions today which is available in India, all of us, caters to the hospitalization and the emergency. The preventive and promotive are kind of, some people are already thinking about it. Nothing has been done much in that space. Outpatient cover. So if you have to look at every 100 rupees that an Indian household spends, right, around 70 to 75 rupees he is spending on the outpatient care, the non-hospital care cover, right, which is obviously out of pocket. Now, do we have solutions for that? Yes, as a part of the hospitalization cover, there's something called pre-hospitalization, there's something called post-hospitalization, which largely caters to the outpatient cover. But not many insurance companies have. We have a product which is a standalone outpatient cover, which gives an unlimited consultation to the insured person. It gives a limited cover for the pharma purchase and the diagnostic purchase. People have started looking at it. We do also see other players who are having such innovative solutions around there.
Mr. Patnaik, I have a question for you since you are representing regulator. There have been reports that insurance companies deny cover to people who are above 50, though IRDA has set the limit of 65 years if I'm right. So as a regulator, what is your stand on it? Because there is no proof that policy has been rejected. You go to the branch and it's a contract, they just say no to it. So as a regulator, what is your take on it?
I mean, if anything is not covered when a particular age, that's what you are trying to talk about. In fact, if it is, any particular product, when it is filed with the regulator, that has to be examined. Okay, and it has to be in synchronization with all the whatever pollution guidelines, all the regulations, everything. But at this point, I would like to tell one thing, that the regulator does not interpret the designing of the product. What the mental illness will be covered or not, we cannot say. Only thing, when the product comes, they will examine whether whatever they are covering, that is in sync with all the regulations or not. When it comes to this particular thing, normally, as you told, there are certain things beyond a particular age they are not covered. But 50 age, I think, I have not come across this 50 age. It is, I think, beyond 60 or 65. It is not so early in the policy. I mean, I'm not aware of this particular thing. But we try to, as per regulation, we try to nudge them that this kind of thing should not be given. And once everything has been agreed, whenever a product is filed with the regulator, there is a lot of queries are raised, then it goes back, then there is an actual department, a lot of things happens. But once everything is agreed, like prospectus, policy wording, file and use, or use and file, whatever it is, everything is agreed, there cannot be any change or there cannot be any deviation. And every company is expected to display it on their website also. And the regulator is expected to do, on the spot, they can go to the particular company because, like inspection happens here. So once they can only take some samples. Or if any particular complaint comes, that can be examined. And offsite inspection also take place. What I mean by offsite inspection is sitting in the regulator's office, we can go to the website of the particular company. I recently found in one company that said this is the exclusion. Whereas that exclusion was not agreed, then it was cleared by the authority. So then immediately took up the matter with the particular insurer. Because another insurer said you have allowed that exclusion. So we are not allowed. So like these things can happen, so disputes can happen. But unless it is brought to the notice of the regulator, or our people will go there and do some sample check, because each and everything cannot be verified, then immediately we tell the insurer that this is not in order.
To sum this up, I would like all panelists to come up with their wish list, which they think can be done from the side of central, state, or at the company level to make health insurance more affordable. If you can quickly sum this up. Mr. Kumar, if you can give your thoughts.
One thing which we have been articulating with the government of India is that today every health insurance should be exactly excluded from the income tax payment. So that is almost like making it mandatory kind of a situation, because one of the major reasons the life insurance business has really picked up is because of the income tax benefits that it has. Today it's only up to 25,000, and that has to be the limit, has to be enhanced. We've been articulating in a large way. Second is we have an urgent requirement of a regulator in the health sector, the hospital, which is a crying need. West Bengal has already introduced a kind, and we are really seeing the results. The hospitals are much more cautious and diligent. Once this, there's another alternative is the health ombudsman, who can really look into the claims and dispose it of. These are all the demands that we have been articulating with the government.
Mr. Sen?
I think Mr. Patnaik could come to our assistance, and one of the areas which is a huge area of concern is the group medical policy. Because to a large extent, our numbers reveal that the individual medical policies are still fairly decent, manageable, but it's the group medical which just breaks all rules, and then when you're in the competition trying to reach your top line number, you kind of blow all caution to the wind, and you come up with rates which are not what should I say, which are not there. You shouldn't be quoting those. So probably the regulator's office, the ombudsman, doesn't look at group policies, and the complaints which go to the ombudsman's office are individuals. But for the group medical, and there are times when, for whatever reasons, you are maybe asked to pressurize also. You're asked to continue with the relationship. I remember when I joined this private sector company about 5 months ago, I let go of a very large account. To give you numbers, 110 crores. I'm still reeling under that, trying to make it up. But I figured it was something which I couldn't handle, because besides the claims which came around, the TPAs and the other people, they were getting bullied by, people at the various centers of the insure. Now, that is not desirable at all. So probably, to my mind, if we can sort out the group medical, things are going to be fine.
Nandini, you have something to add?
Reinforce in the order of priority again. First, an exemption from GST. Second, if that can't be done, right, at least take the ceiling to 5% from 18%. Third, in order to help the senior citizen, because we have been hearing a lot, a decade or two later, all of us also will be there. Right? So in order to make some movement here, maybe the government of India should look at, if not to the entire population, but at least for the senior citizen, exempt them from the GST. Third is on the PF Act. Why not amend the Act in a fashion that whatever the accumulated funds, right, for the individual, post-retirement, they can use it for sponsoring their own health insurance premium, right, and then debit it from the PPF. And of course, the last wish list, which is the biggest one, which comes under the bracket of desire, is make health insurance mandatory for at least APL.
According to me, to sum it up in 3 points, we need support, 1 from the government, 2 from the insured in terms of co-payments and all. Third, we have to look for innovative affinity channels through which we can increase the spread and reach that magical figure.
I think everybody's spoken about what they expect from the center and the state government as well as mandatory health insurance or GST is concerned, and the need of a regulator for hospitals. I would kind of put it to insurance company and say, technology is a lot of innovation can happen through tech, right? If you look at the Flipkarts and the Amazons, the Olas, the Ubers today, practically we can't survive without an Ola and Uber in a metro, right? Somewhere, what is it that they've done? They've got those cab aggregators together. Right? They've brought in convenience. Somewhere, I would say tech or digital can be used for a lot of experimentation. We will do 10 experiments and one might work, 9 will fail. I think somewhere tech has to be used as an experimentation platform to see what kind of products will work and what kind of products will not work. I think my only request to companies and the regulator would be to see each company is actually doing 2 experiments in a year, and then see what is working and what is not working. And then use tech as much as possible to run these experiments, because that will control cost, that will create a far better customer experience, and eventually help us increase the health insurance coverage. And once that happens, premiums automatically go down and become a problem.
Mr. Patnaik, the reverse question to you: what do you expect these companies to make health insurance? What is your portable?
My wish list is 3. First, from the company, there should be, from the regulatory viewpoint, there should be kind of product so simple, just like savings bank accounts. So everybody understands, because now the insurance language is so complex. People don't understand what exactly it contains, and many people don't read also the literature. So it should be so simple that anybody can understand what this particular insurance stands for. At least one such product should be there for pan-India where people can understand, number 1. Number 2, that people should be so much aware, because mandatory will not make any help. Because recently I read one report, 70% of the 2-wheelers are not insured. Only when they are new purchased, then they get mandatory cover. Subsequently, they don't go for renewal. Even there are some 4-wheelers also where people also don't go for insurance cover after once it is expired. So there should be kind of awareness built that people should come forward voluntarily to have all kinds of insurance, whether it is motor or it is health or anything. And third thing is this taxation part, this GST, this tax, that tax on health, life, motor. I think the country needs some kind of there should be any kind of tax. Let the insurance industry mature, because it is still struggling. So at least on health insurance, on the one hand we are getting up to 25,000. I think that is also not adequate. At the same time, the GST kind of thing, because many times people, the moment they know there is a tax, whether it is insignificant, people are put off. So from the government side, I would expect that there should be any kind of taxation on the insurance.
Okay. The floor is open for Q&A round. If you have any query, please do ask.
Yeah.
Can somebody give mic to me?
Pass the mic, please. Jaldi. Please introduce yourself.
This is Sydney Anderson here from the Association of Medical and Wellness Tourism. I would just like to draw the panel's attention to the title of the panel and perhaps some perspectives on the international best practices suitable to Indian scenario. I don't think we've heard any points on that.
So, Pankaj, if you can tell us about some international best practices which we as Indian company can also adopt.
Hello. All right. So, like from the reinsurer's point of view, what we have done in last few years. Now, as I said when I was talking that we put health into two baskets. One is the retail, and another one is aggregated retail. When it comes to retail health insurance, the reinsurers do not really play a vital role there because it's a low ticket, low PML size product. So typically the direct insurers are basically driving the entire product. But to give you some example, for let's say for aggregated retail product. So as reinsurers, what we have come up with certain IT tools to basically identify if there are any malpractices or frauds happening from any of the stakeholders. And I say stakeholders, for example, let me put it this way, that for a particular aggregated retail scheme, there are a few hospitals, and if they kind of engaged into certain kind of irregular activities, so we have very sophisticated digital softwares with us, which we have imported using best practices in India to identify those frauds, and that has helped us in bringing down the cost of the product significantly. So basically we are talking about affordability. So now coming back to where I started, it's a misnomer. Sometimes we say that the incidence rate has been very, very low for a particular product, but what we miss here is that because number of lives are not as many as we wanted them to be, so a very low incidence ratio can wipe out the entire premium. And so the emphasis has been on reducing the cost. And so I gave you one example that we kind of imported or borrowed that best practice in terms of curbing that fraud to mitigate the cost of the product. So we can replicate it in other lines of health insurance businesses as well.
Yes. We'll take two more questions because we're running short on time.
So my question is, for example, Mr. Kumar, you said that there's a preferred network, right, that you started to build. Now the approach there is really to say that there's a fee for service. So if you go to a doctor, if you go to a hospital and there's a cardiac surgery, there's a fee for service, and they're going to comply for a rate. Have we started thinking about the fee for outcomes or value for treatment, case-based fee that we pay out to hospitals so that the entire case's cost is controlled versus actually the particular service?
No, the way we go about in PPN is slightly different. We go to the hospital and we list out about 100, 150 procedures, which is by statistics is most common. And we fix a package rate for each of them. So the hospitals would have probably a room rent and everything, but then when we, for example, let us take a case of angioplasty or kind of cataract operations and many such things. We agree with the hospitals on a fixed kind of fix. And we tell the customer that this is the amount, you need to pay only that. And to that extent, we'll straight away pay the hospital. If there's anything more to that, then probably the customer has to pay that. So this is an interface where TPA also works in. They see to that the hospital adhere to this package. So we have been able to arrive at this kind of a package deal with most of the hospitals, many number of hospitals. And the RSBY, state governments also has come out with this kind of fixed rate for various practices. Most of the hospitals are adhering to it.
But have you been able to link it to medical outcomes?
No, I didn't get that medical outcome. How I didn't understand the
for
question very
example,
well.
you might be paying two different hospitals the same 10,000 rupees,
Yeah.
but one might actually result in the patient not having a recurrence of the disease, not having other diseases.
No, that is that is the hospital quality. When you select the hospital according to that, the doctors according to that, we really do not correlate the outcome with the package rates. We do not really see whether the patient in this particular rate at this 10,000 rupees was a cataract showing a much better operation than another hospital which did it at 10,000 rupees. So that kind of a comparison we don't have. But most of the hospitals, between the competition, has to provide the best delivery.
Yes, the last question.
Sir, is there any product which combines healthcare insurance and life insurance? And if it's there in the product, then why people aren't buying that product?
Life insurance do give health riders. The only difference is general insurance companies generally give reimbursement of actual expenditure. In life insurance, mostly in lump sum amount.
So there are products, these are called combi products, which are a joint co-creation between the life insurance companies and the standalone or the general health insurance company. They are currently available. They have been recently introduced. There is a separate regulation for the combi that has been governed by and guided by the regulator, and it has been published only a year back. So you will see a lot of these combination product coming and hitting the marketplace almost by all. If I'm not mistaken, all the private insurance companies are already in discussion with some of the other giants in the life insurance side.
And sir, one more question.
One small question to Brendan Senali. As private companies come to some directions within themselves to bring GMCs at par with GIPSA companies, because as such 4 GIPSA companies have chalked out some strategy not to go below some codes. So can we expect something from private sector in this GMC's work? Some coordination?
There are no separate rules. There are no separate rules. It's just based on your prudence. When you look at the loss experience of the previous year or the previous years, and then you make your quotation accordingly. And if you think that it is worth it, you do that. If you don't think it is worth it, you exit out. That is how, in fact, the public sector companies also, to an extent, keep that in mind. But it's just that there are times you get carried away in terms of enthusiasm and quote what is not viable. I told you what I did.
I think that brings us to
With this, we come to an end of this session. I really want to thank all the panelists who took out their valuable time for this session. Once again, thanks a lot.